So to start off, want to welcome everybody. This is the Clinical Problems webinar entitled Race and Pulmonary Function Interpretation. My name is Anthony Esposito. I'm an assistant professor at Northwestern, and I specialize in interstitial lung disease. I'm also a web committee member for the CP Assembly and on the webinar subcommittee putting this together for you today.
Hi, my name is Lijo Parambil. I'm an assistant professor at Temple. I'm also part of the Clinical Problems webinar committee putting this together today. We'll be your moderators for today. As you all know, there's been recent changes to the guidelines for interpretation of PFTs, especially regarding using race-based algorithms. Earlier last year, the ATS had put out an official statement regarding this issue. Since we all had some time to kind of digest it, we thought it would be an excellent time to dive into it in a webinar form.
Okay, and today we have with us, as I mentioned, 4 different speakers. The first speaker who will be presenting today is Dr. Nirav Bhakta. He is an associate professor of medicine at the University of California, San Francisco School of Medicine, who's also one of the co-chairs of the ATS committee that put out the statement on the PFT and race interpretation. He will give us the historical context, race and racism in PFTs. And off to Dr. Bhakta.
Thank you, Anthony and Lijo and the whole Assembly on Clinical Problems for hosting this webinar and inviting me to speak. I'm an associate professor at UCSF. I'm an adult pulmonary and critical care physician and was co-chair of the ATS statement, and currently I'm vice chair of the ATS PFT committee. And so here today, we're going to talk about the genesis of this statement on race and ethnicity and pulmonary function test interpretation, which was the output of an official ATS workshop, which took place in May of 2021. And I want to give you some of the history of race in pulmonary function testing. So this group was just an amazing assembly of expertise that participated in the workshop here, including my co-chair, Christian Beame from the University of Arizona, and then people from many levels of training, many different areas of pulmonary medicine, experts in COPD, ILD, asthma, occupational medicine, and others, people from adult and pediatric pulmonary medicine, people focusing on the history of medicine, such as Dr. Lundy Braun, experts in genetics, such as Victor Ortega, and physiologists, and so much more expertise here. Now, each one of us came to this workshop with our own journey. Some were in this space and aware of the issues for over 20 years, writing about them, such as Lundy Braun, who is a scholar in race, society, and medicine, and specifically in pulmonary function testing. Dr. Peter Burney had published critical data in 2013 that questioned the use of race-specific pulmonary function test equations. And many may have had their own journey. I'm going to tell you more specifically about the journey that I had to this workshop. Personally, I was not aware of Johnny Meyer's 1984 paper in the South African Medical Journal that questioned the use of race-specific equations and brought into play the effect of societal and environmental influences on pulmonary function, nor Dr. Goldman's paper from 1996, nor the PBS documentary on race and society and the illusion of race in 2003. I took all of that, the use of race in clinical algorithms, for granted. Like the majority of people here, I subscribed to the race-specific approach to pulmonary function because that's what I was taught. And this is how it went. We were taught that when you take large groups of people and study their lung function, such as shown here in this Global Lung Function Initiative data published in 2012, that there are residual differences in average pulmonary function between groups of people when they're categorized into race and ethnicity categories here, after adjustment for age, height, and sex, with people self-identifying as white having a little bit higher lung function across the age spectrum here for FEV1 compared to other groups. The output of this was that if you took a 47-year-old female who's 5'5", just as an example here, with a measured FEV1 of 2.0, we would say, well, okay, if the person identified as African American and we use the African American equation, we would say their value is 79% of the predicted value of 2.53, and that their value is greater than the lower limit of normal of 1.93, this statistical fifth percentile that has been recommended to be used as the cutoff by which to gauge your suspicion for there being a problem with the pulmonary function. Yet on the other hand, if we were to use a Caucasian equation, this GLI white equation here, we would say their value of 2 is less than the lower limit of normal and that there is a problem. This decision we created here has real implications. We have created systems based on these cutoffs where we will then ask and have different answers for whether respiratory disease will be considered or whether additional tests will be done, whether there will be a referral for lung transplantation or the person will be eligible for disability or eligible to work. That's how I came into this project. And then what really awoke me was the 1619 project that was published in the New York Times in 2019. And in specifically this article in August, where myths about physical racial differences were used to justify slavery and are still believed by doctors today, was the main headline. And of course, that caught my attention. And many of the statements in the article caught my attention. They hit hard. They hit me personally. And I asked myself, wow, am I a racist? Wait, what have I been doing? And many of us went through these feelings and these questions. A group of us within the ATS PFT committee and the Health Equity and Diversity committee decided to write a response to the New York Times, in part at that time, trying to defend ourselves. And that's because that's the state that we were in at that point at our level of inquiry into this project. It didn't get published, but we did then recognize that not only did we have a lot of questions and not a collective lack of understanding, but that many people were pointing to the ATS guidelines as responsible for promoting race adjustments that might propagate racial and ethnic healthcare disparities. So these were guidelines on how to perform PFTs, how to interpret PFTs, and how to diagnose disease across all areas of pulmonary medicine. With that backdrop, in 2020, a few members of the ATS committees on PFT testing and health equity and diversity identified that an ATS workshop would be a great mechanism by which to have this discussion and understand how much guidance we could give to the committee. We submitted the proposal in August of 2020. It was approved by the end of 2020, and then we eventually had the workshop in May of 2021. Along the way, we had further support for this workshop. For example, many of you may know in September of 2020, a member of Congress asked the ATS to reevaluate the use of race and ethnicity in clinical diagnostic tests like PFT, and many professional societies were similarly sent letters like this. And we were requested to provide guidance, and that these issues are not new, they're pervasive, they're disturbing, and they warrant prioritization by the ATS. The ATS responded and said, yes, we agree, and we've already decided to have this workshop. Similarly, in the fall of 2021, New York City formed the Coalition to End Racism in Clinical Algorithms, and on World Lung Day in the fall of 2022, they too wrote a letter to the ATS to urge immediate guidance and to address this issue. Importantly, while this outside pressure energized us and convinced us, sort of supported our conviction that this was an important issue, I commend the ATS for shielding us from the political pressure and repeatedly telling us that we were free to produce whatever document was the natural outcome of our workshop. and that was important that we had an open discussion and not be pressured by these kinds of statements. We also had further inspiration from other areas in medicine. Many of you know that Dr. Vyas, Dr. Jones, and others here published this really fantastic opinion and comprehensive review piece on the use of race in clinical algorithms. And this too, and the response to this high-profile paper, again, convinced us of the need to work on this. And in an era when it was very difficult to bring this large, diverse group of people to talk about such a difficult thing virtually during the COVID pandemic, this kind of inspiration was important to, really, again, give us the energy to do this hard and important work. We were also aware that the National Kidney Foundation and other professional societies were working for a number of years on addressing the use of race in EGFR calculations, and that in 2021, their final guidance was issued, and again, told us that we needed to work on this, and it was very timely to get some guidance out soon. The workshop was held in May of 2021 over the course of 2 days, again, virtually, where we talked about the history of race and PFT interpretation, the determinants of pulmonary function, clinical implications, and then how we were going to move forward. Some of these things you will hear about further today. And I'm going to specifically talk about the history section here before handing it off to the other speakers. Together, we learned that there were challenges to the use of race over time, and that we were increasingly recognizing them together in medicine and as a society, that race is not uniformly defined across time and location, that it can mask modifiable risks for reduced lung function and disease. It is not a proxy for genetics, and that variation in the genome within races is much larger than between race categories. They're limited, do not account for many other effects of background, and that residual differences in lung function between race categories had been used for many years to justify an idea of innate inferiority, even if that was not the explicit thinking of clinicians on the front line using race in medicine. In our history section of the workshop, led by this scholar here, our leading light in the history of race and pulmonary function testing, Dr. Lundy Braun from Brown University, that the views that racial categories reflected innate characteristics really drove the organization of pulmonary function observations while making everyone ignore all the other factors that contribute to pulmonary function, the real underlying determinants of pulmonary function that were hidden by this disproportionate emphasis on race. We learned that the majority of research that formed the evidence base for lower lung function in non-white populations, like the GLI data that I showed you in an earlier slide, did not examine socioeconomic status. And that although physiologists justified race from differences in the ratio of limb length to chest height, we learned that this view is quantitatively insufficient and expected to reflect the environment. It's not all innate. In my final slide here, I want to tell you how subsequent research also made us re-examine the history and what people took for granted. So one of the key publications that formed a solid, you would say, scientific basis that people pointed to for the use of race-specific equations was a study commissioned by the US government and conducted by Benjamin Gould on United States Civil War veterans. So here, Benjamin Gould categorized vital capacity among these Civil War veterans and showed that lung function was lower in Black individuals. Dr. Ba, who's a speaker here today, many years later, had a very interesting idea to reanalyze this data and posited that if genetics were a driving factor for the differences in lung function between racial and ethnic categories, then you would expect people who identified as mixed race and who could have very little African American ancestry in them, but by the standards that we know in the United States at that time, and unfortunately in some cases true in many places today, that even with a little bit of African American ancestry, people would more likely have experienced social and environmental influences that were more like people that identified as African American and would be labeled as African American than people who would identify as white. So again, mixed race individuals would be treated as African Americans by society and structural institutions more than they would be viewed as white people. And indeed, Dr. Baugh found in this analysis, when looking at vital capacity versus height, that the vital capacity between people identifying as African American and those labeled as mixed race overlapped and were different than the numbers from people who were identified and labeled as being white, suggesting that social and environmental influences were a much stronger factor than genetic factors.
Great. Thank you very much, Dr. Bhakta, and I appreciate you setting the stage for our speakers that are going to come after you. Thank you for your great work on that project as well. Next, we have Dr. Gabby Liu. Gabby is an assistant professor of clinical internal medicine at University of California, Davis School of Medicine, who will go over the data that challenged the use of race-specific pulmonary function prediction equations, lessons from the cardio-lung cohort, and other studies. I'll leave it to Dr. Liu.
Great, thank you. And thank you, Dr. Bhakta, and thank you to the committee for inviting me here. So yeah, let's just get started. So I think it's helpful to sort of take a step back and think about how we use these PFT reference equations today. When we're inputting our patient's data into these equations, we're really asking, how does our patient's lung function compare to a healthy reference population? And I put healthy in quotation marks here because participants fulfilling this criteria may fall under a wide spectrum of health, as we now know that it's very possible for a non-smoker without diagnosed lung disease to have evidence of subclinical impaired respiratory health. So I think that's just at least one factor to take into consideration when we're comparing our patient to a reference population, especially when, as you see here, the amount of data that is used to determine what is healthy for a non-white population in these race-based reference equations is significantly less than the amount of data we have for white populations. And notably, all the data for our populations of African descent come from African Americans. The majority of the African American participants in the GLI reference population, I just want to point out, come from NHANES 3, which is an American population-based cohort that enrolled people from 1988 to 1994. And so when we consider who belonged to this and who was enrolled in this population study, I think it's important to consider that a 40-year-old in this study would have been born in 1948 to 1954, attaining peak lung function in the late 1960s, early 1970s. And then when you consider an 80-year-old, they would have been born 1908 to 1914, with their peak lung function being attained late 1920s to 1930s. So of course, we still have a lot of health disparities today, but I think it's also important to consider that a lot of the participants in this NHANES 3 cohort, which again make up most of our GLI reference population, would have been living under legalized segregation in the South or a de facto segregation in the North and the West. So we really need to be considering how structural inequities in health and differential exposures across the life course may have affected the lung function of our reference populations, similar to how Dr. Bhakta pointed out. And a similar slide to Dr. Bhakta's is, considering how this plays out today when we're examining a patient's lung function. So again, considering in this case, a 40-year-old man who's 6 feet tall and has an FEV1 of 3.5 liters, considering that if that person self-identified as African American, that would be considered normal lung function for that person. However, if that person instead identified as Caucasian or Northeast Asian, that would be considered abnormal for that participant or for that patient in front of you. And just as reference here, I also put how that lung function would be considered using some of our race-neutral equations like the GLI other, which is a predicted lung function based on the average of participants from the 4 main groups, so an unweighted average, versus the newer GLI global, which is a weighted average so that each group contributed equally. And so, I think if we consider this person, if we consider an FEV1 of 3.5 liters normal for an African American man, but abnormal for a Caucasian man, this really begs the question of whether are we just normalizing lower lung function, or are we normalizing worse lung health in African American populations and other non-white populations? Because I think it's clear, looking at what these equations do, it's inherent in these equations that we're normalizing lower lung function in Black adults. So in this data that you're seeing here, this is from the Cardia cohort, which is a population-based cohort of US adults, which were roughly equal in numbers between Black and white participants. And on the left panel, when you compared the histogram of distribution of FEV1% predicted between Black and white men using the same equation, a race-neutral equation, you can see that Black adults in this study overall have lower lung function than white adults. However, when we use the race-specific FEV1% predicted equations, you can see that this shifts to the right, shifts up the lung function for Black adults, normalizing their lower lung function, so that now it matches up more closely to white adults in this study. So our group tried to answer this question of whether or not race-specific equations are actually normalizing worse lung health in Black adults by examining CT evidence of, specifically emphysema, CT evidence of impaired lung health in the Cardia cohort. So what we did in this study was that we stratified the cohort by race-specific FEV1% predicted, and then we examined the prevalence of emphysema, comparing it by race and by gender. And what we found was that among those with an FEV1% predicted between 80 and 99%, the prevalence of emphysema among Black men was 16% compared to 4% among white men. And then among people who would be considered to have above normal lung function, we found that 14% of Black men in this group had emphysema compared to just 2% among white men. When we then used race-neutral equations, the GLI other equation to calculate FEV1% predicted for both Black and white participants, we found that these differences among people with an FEV1 between 80 and 99%, these racial differences in emphysema prevalence were decreased. We had similar findings among women in this category, such that when we used a race-specific FEV1% predicted, Black women had higher rates of emphysema than white women. However, when we looked at a race-neutral FEV1% predicted in this range of 80 to 99%, that now Black women and white women had similar rates of emphysema. And we felt this was an important reflection of lung health because emphysema has been associated with lung function decline, exacerbations, and mortality, and is generally considered an important marker of sort of pre-COPD or impaired respiratory health. So in this study, we also noted that respiratory symptoms were more common among people with emphysema. So taken together, we felt this study provided some evidence that race-specific equations were normalizing worse lung health in Black adults, particularly among an at-risk group, i.e. those who had an FEV1 between 80 and 99%. So subnormal, but still within what would likely be considered a normal range. But our study was really building upon prior evidence that also suggested that race-specific equations were normalizing worse lung health among Black adults. So several studies have shown now that Black adults have lower survival than white adults for a given FEV1 or FVC percent predicted or Z-score. And that's what you're seeing in the panel on the left here. But these studies have also then examined race-neutral FEV1 and found that this racial difference in mortality is decreased or eliminated when adjusted for a race-neutral FEV1 or FVC percent predicted or Z-score. And then in a study published last month, Nan and colleagues compared various different race-specific and race-neutral or race-free equations for FEV1 and sought to see how these equations, how well they do in explaining CT abnormalities, specifically emphysema, air trapping, or increased airway wall thickness, and how they explained respiratory symptoms. So in this graph on the left here, you see the receiver operating characteristic curves for these different equations, FEV1 percent predicted equations, and you can see that a race neutral or race free FEV1 equation performs just as well as a race specific equation. And then when they looked at multivariable logistic regression models, which included FEV1 to FVC ratio, smoking pack years, CT scanner, smoking status, gender, as well as the percent predicted FEV1, they found that race-neutral equations performed pretty similarly to race-specific equations as measured by the Ayakake information criterion. However, interestingly, they did find that race-neutral or race-free FEV1 equations may actually improve model explanation for dyspnea. So when we look at these ROC curves, I know it's hard to probably see on your screens there, but where it starts to separate those two higher lines with the greater area under the curve are actually the GLI global and the GLI other. And then when they looked again at these multivariable logistic regression models, they actually did find that the race-neutral or race-free reference equations, which are outlined in red, actually performed better than the race-specific equations, as evidenced by lower AIC values. And so I don't want, I'm not going to go into great detail because this is a paper by Dr. Ba and his colleagues that he'll be going over soon, but I didn't want to leave out this really important paper where their group showed that essentially these race-specific reference equations were likely, again, normalizing worse lung health as evidenced by greater amount of respiratory symptoms for a given FEV1 percent predicted among Black adults versus white adults, and that this difference was eliminated when looking at race-neutral FEV1 percent predicted. So in summary, this is just a brief review. This is definitely not an exhaustive review of the evidence, but some considerations that challenge the use of race-specific prediction equations are that, again, they discount social determinants of health and they normalize lower lung function and worse lung health in non-white persons, as evidenced by increased CT abnormalities, mortality, and respiratory symptoms in Black versus white adults for a given predicted lung function. So, wonderful. And I'll let Dr. Ba take it away from here.
Yep. Thank you very much, Dr. Liu. Next, I want to introduce Dr. Aaron Bao, Assistant Professor of Medicine at the University of California, San Francisco, who is going to give us a look at clinical implications for adult medicine of race-specific and race-neutral pulmonary function prediction equations.
Thank you so much to my co-presenters, to the ATS committee, and for all of you for joining us. It's a really exciting time of change, not only because it's a new year, but we are seeing new things in medicine. We're adjusting still to new diseases like COVID-19, and we're increasingly grappling with even the changing demography of this country. And I think all those things help us to inform this discussion that we're having here today that's really vital. And my colleagues have laid out a lot of things that are, foundational, important to that. And I think just one thing to concede, as Dr. Bhatia was kind of outlining in his own journey, is that, these are times of uncertainty, right? And as I've went through my own evolution in this process and learning from first hearing about this issue to being where we are today, I've certainly had a lot of change and a lot of growth. And so I don't think that's unusual. And questioning and skepticism are important, right? And so what are our tools to navigate through these times until we come to a more settled sense of how do we move forward in a safe and responsible fashion? Well, one tool that I've found is really fundamental is that old saying that, like, if you think about like a tree or something, the youngest sprigs and twigs might be pruned away, but really the roots, the trunk, the big branches are the fundamental things that will always stay. And so what I want to do with you all today is just take some time and think about, really asking some fundamental questions about what does this new transition to race neutral or to a multi-ethnic composite reference equation for spirometry mean? And we'll just do these basic, like, investigative questions that you might ask even outside of medicine, right? Like who, what, where, when, why, and how. So first, who is being impacted by these? What are the different populations that are going to see real change as a result, and how much change are they going to see? What is the scale of that? Is it, a major change or minor? And then where in the disease process or in their lung health or in, are we more likely to see big and small impacts? And I think even though those questions are very basic, they can help us get a real sense of what this is going to mean for us day by day in the clinic, not in the great sense of, on the population level, not in this broader philosophical sense of how this interacts with our, understanding of the world and culture and meaning, but just in terms of the patients we see every day. So let's get started. This is a study that came out this summer from Dr. Kanj and his colleagues. Now, this is one of about the 3 or so studies, all of this same kind, where they're retrospective single center reviews that try to look at if we reapply existing or I guess the new reference equations to existing records of spirometry that we've done at our institution, how would the results be different? Now, there is lots of convergence in these results. All agree that our Black identifying or African American patients are going to be those most affected in terms of the biggest change in the relative proportion between previously normal to now abnormal spirometry. And you can see that right here. Not a lot of change in obstruction, but in potential restriction, a significant fraction here, 50% relatively, about 10% absolutely, have this new change, a new finding of potential abnormality. All also agree that our Caucasian or our non-Hispanic white populations are going to see a smaller magnitude of change on average. But this study stands out for a number of reasons. It's was done at the Mayo Clinic affiliated centers. And so it is, even though it's only a 3-year review as opposed to the 10-year review done by Alex Moffat and colleagues, published in JAMA Network Open, or the impressive 29 year review done by Margaret Connolly at the University of Rochester. This is the most diverse group, and including tabulations for Northeast Asian, Southeast Asian, and mixed race populations, and also has the highest fraction of Black participants. So I do want to highlight, as we continue in this journey, we do start with, obviously where this arose for many of us was in things like the 1619 Project, considering the history of race in the country. And so there's this understandable and laudable focus on Black-white differences, but also wanting to be inclusive and think about how are all the populations we're going to see be affected. And so I like that he does that. We see that there is, basically this almost more of an exchange between the Southeast Asian, and that, less will be diagnosed with obstruction, but more on average might be diagnosed with restriction. And then for mixed race, it's kind of a flip back and forth. But what does this really mean? A diagnosis has no relevance outside of what it can tell us about our patients. And so in this study, they start to get into this by asking, well, among those who are uniquely diagnosed as obstructed by the GLI global equation, that's the new reference equation we're recommending now, they found that they're more likely to have some air trapping and more likely to have symptomatic dyspnea. And that makes sense in light of the data that Dr. Liu was just showing us. But let's try to dig into this a little more. And to get more into this, I think we should go to some specific disease. In that question. All right. Before we do that, I think I just want to say this is unpublished data from Spiromics, just looking at our cohort. And one thing I want you to understand, the shape of this graph is the red line is the mean values all the participants across all races had when using the Hankinson 1999 equations from NHANES 3. The blue lines is the variance that we could get when we go to the GLI global among all our participants. So some people will be getting lower values, and you might imagine, okay, maybe this is a African American participant or Southeast Asian. Some will be getting higher values, and this could be maybe like a non-Hispanic white or Northeast Asian, or even though these are mean, so this could be of any race, but on average, right? The point I want to make to you is that the width of this variance gets narrower as you get to lower levels of lung function. So we would expect there's going to be more profound shifts as we have higher levels of percent predicted lung function, lower as people's overall lung function gets worse. So armed with those kind of general patterns of this is how things are changing on average across racial ethnic groups, and this is how it changes across percent predicted lung function. What are the studies showing us? So this is my own work from the Spiromics cohort of heavy smokers. This is at least 20 pack years of smoking history with or at risk for COPD, as was summarized quite beautifully. What we looked at is two measures of symptom burden in there. COPD assessment test or the St. George Respiratory Questionnaire, and said, well, if this is supposed to be normalizing for these intrinsic differences that have no clinical impact, then what we're trying to get to is this idea that for one lung function, I should have one level of symptom burden. But in fact, we do that with a race neutral or a composite ethnic equation, so that for 70% here, a Black and a white participant have the same level of symptoms. Whereas very different, 70% here, a white participant has many fewer symptoms than a Black here. And that's just an example of the kind of work we did across all these different outcomes, looking at some self-reported symptom burden, some radiographic criteria, some functional criteria, but looking at them all separately, disaggregated from one another, and without respect to severity of disease. And so these became questions of like, okay, but that's not how we think about things when we're in clinic. We do integrate all their symptoms. They are separated by severity, right? And so this is very helpful and interesting work from Dr. Reagan recently. And I want to point you to, this is done in the COP gene cohort, so the sister cohort of Spiromics. And I think there's a couple of things that we can note here. One is that if you look where some of these symptoms are the starkest, like dyspnea, it's in these early, gold 0, right? And then you look over here, when they applied the race neutral categories, the race neutral reference equations, where are the biggest shifts happening? Look at the A2 and B2. This is using the GLI global equation. And you see the biggest shift for these Black populations is actually in this gold 0 to prism. So they're reclassifying in a way that makes sense. And so even when they use the COPD score, which aggregates some of those different things that we have been looking at separately. And it's not, by random chance, but it's that even when you look at everything together, that the mean values for people reclassified into these more severe classifications of lung disease, their means were, similar to the more severe group they are coming to, not the less severe one they are coming from, which suggests that maybe originally we had misclassification. And also, again, to highlight that this is happening mostly on the early parts of disease. Dr. Lou already talked about her study, and again, I'll just highlight that biggest change was seen in the 80 to 99% group, the early part of disease. Won't spend more time there. But I do want to show you, this is the original graph from Burney and Hooper. And this is all-cause mortality in the general population using the non-Hispanic white equation. So not even using a multi-ethnic composite like we have. But again, we see that when you use white equations for everyone, you get, again, like my own work, a very coherent, for a single lung function, you have a single mortality risk. Whereas when we try to use these race-specific equations, you get this weird separation where the same lung function means something very different for the mortality of different populations. Now, I will make 2 points in comparing that to this update done with Meredith McCormick's work in the GLI Global. First, I'll say there's this similar convergence. So I'll suggest to you that the particular composite equation that you use, or the particular unified equation you use, may be less important than just putting everyone on one scale in the first place. And I'll also point out to you again that even when you use race-specific equations, this convergence is there at the low end among people with very severe lung function, where we expect we don't see much change. But it's in this higher lung function where we could be missing something early on that we're really improving things by going to this single equation. Now, this is looking at risk of hospitalization. And this is work by Ariel Amala Sachs. I'll just say that, again, this kind of undermines this idea that race was very valuable to us, because trying to look at the prospective risk of hospitalization in a higher quality study than the cross-sectional ones we've been looking at so far, there's no benefit. And similarly, I'll say that when we try to look at risk of complication, this was a composite outcome, respiratory failure after surgery, need for supplemental oxygen. There was really no benefit, again, to adding race to these equations. But there was, as I close here, a finding. This is a Dr. Bonner study. They were doing quality improvement, and so they found that 90% of hospitals in this Michigan consortium of about 16 used race-specific equations to calculate risk for lobectomy, and that when they took away the use of race-specific equations and used GLI other, or they call it race neutral, but this is, again, like Burney and Hooper, the non-Hispanic white equation, you get surgeons less likely to refer to lobectomy, where disparity already exists. And I will point out that lung cancer is an end-stage disease, whereas earlier we're talking about things early on. So how do we put this together? Well, 2021 work from Adam Gaffney and others showed that in pulmonology alone, African Americans have about 0.63 odds of receiving specialty care. And so this ability, who gets referred, who gets to see a specialist, who has problems triaged early on, may be an important part of the story in how long-term outcomes and health disparities emerge. By switching to a race-neutral or composite reference equation, we can increase the sensitivity for disease in some of these non-white populations, like African Americans and Southeast Asians, and maybe try to start to address this. But this impact is seen earlier in disease than later. And so we really need to have this conversation, as the Bonner work shows us, between, now that we've changed and we're getting these correlations to outcomes, are the old thresholds we were using really still appropriate? Thank you, and I'll hand off.
Thank you very much, Dr. Bao. Next, we have Dr. Stephanie Levinsky-Desir, Associate Professor of Pediatrics and Environmental Health Sciences at Columbia University, Vagelos College of Physicians and Surgeons, who will give us a look at clinical implications of pediatric medicine of race-specific and race-neutral pulmonary function prediction equations.
Thank you so much for allowing me to share a little bit more about our little people or our children as this change in our guidelines relates to them. So I'm going to start us off with the case of Asha, who is a 14-year-old female. She has a history of thoracic insufficiency, and she's followed about twice a year with pulmonary function testing. Some of you may recognize this picture of Disney's first Afro-Latina princess, Asha, from the movie Wish. But this is a real patient of mine that I took care of, and her pulmonary function testing. And as I mentioned, I see her about every 6 months or so. And the first thing I noticed when she came for a follow-up after this visit was, wow, Asha, your lung function is improved significantly. If you see her FVC, the percent reference jumped up from 41% to 51%, and the FEV1 jumped up from 37% to 45%. But the next thing that I noticed was that the race that was recorded for this patient on the 2 separate visits was different, and that was the genesis of the difference in reference equations and my interpretation of her lung function. And the real difference, significant difference between these 2 visits was that during the January visit, she was brought in by her white mother, and during the August visit, she was brought in by her Black father. And so the interpretation of the PFT technician based on the way her parents looked influenced what they listed as her race and the reference equations. Remember, this is back in 2019. So as Nirav mentioned in his introductory talk, it's important for us to acknowledge that race is not a proxy for genetics, and rather it's a socio-political construct. And, you know, the variation of the construction of race and categories across time and location across the world. And so our current reference equations that actually take race into consideration only provide 4 categories, and they don't account for the effects of acculturation, mixed backgrounds, and a variety of other factors. And so the problem about using race and ethnicity in pulmonary function testing is that it contributes to and perpetuates this false idea that race distinguishes people on the basis of innate immutable features. You know, this could potentially be harming people because it's masking the effects of social and environmental factors that contribute to differences, including structural and systemic racism. And, you know, it really also leads to a lack of attention to these potentially modifiable risk factors. And lastly, this practice assumes that lower lung function found on average in Black populations is not clinically meaningful. And this was well highlighted by Dr. Bao in his last talk that just preceded me. And I think it's also very important for us to acknowledge when we think about pediatric populations to know these reference equations that do take race into consideration, who's included in these populations. So there were no Latin American individuals less than 40 years who were included in the GLI reference equations. And even among children who were 5 to 10 years of age, a very small proportion of them were people of color, with 96% identified as white. And the other factors, when we think about what is considered a healthy population, prematurity wasn't included or factored into who was included into the genesis of these reference equations, low birth weight, obesity, secondhand smoke exposure, none of this was brought into or considered when the cases who were included in these reference equations were included. And this is really important, particularly because we know that children experience rapid lung growth in the first decade of life. And so lung development starts in utero and it continues through adolescence and into early adulthood. And this rapid increase in somatic and lung growth during that first 10 years of life in a healthy children is accompanied by a 20-fold increase in forced expiratory volume. So these factors that may be contributing to reduced lung growth in children are very, very important in early life. So what are the determinants or the factors that contribute to lung growth and lung development? So there are maternal factors such as smoking or undernutrition. There's preterm birth, as I mentioned before, lower respiratory tract infections, particularly RSV infection, nutrition, both over and underweight, smoke exposure, air pollution, genetics, and the social environment. And so all of these factors that children experience early on in their life contributes to what trajectory of lung growth or lung function they will develop as they become adults. And it really does determine who is at risk for adult lung diseases. So just to think a little bit about why we use spirometry in pediatrics, what are the purposes? So we use spirometry to diagnose pulmonary diseases such as chronic lung disease of prematurity and interstitial lung disease. We use it to monitor disease progression. So this is, for example, in cystic fibrosis or other lung diseases that are associated with disorders like sickle cell disease or rheumatologic conditions. We use spirometry or lung function to assess response to bronchodilators. Again, we use this in asthma to see if there's an improvement before and after. And we also use it, it's very important in the oncological space, to assess risk for therapies. So when we think about how our guidelines are impacting, or change in our guidelines are impacting the health of children and our assessment of children, these are the categories that we really think about there being an impact. So in terms of the oncological space, one thing I just want to offer just two examples about where we think that, these lung function changes. By and large, there probably won't be as huge of a difference shifting from race-specific equations to race-neutral or composite race equations as there may be in adult populations. But one thing to keep in mind for pulmonary function treatment and the use of pulmonary function testing and the treatment algorithms for chemotherapy, we know that there are a number of chemotherapeutic agents that have respiratory complications, and many of the algorithms that help determine which treatment protocols children should go on use lung function as a distinguishing factor of whether or not they should be added. So this may prevent children, particularly Black children, as was highlighted by Dr. Ball, who are likely to have lower lung function using race composite reference equations. They may have, we may be protecting them a little bit earlier from lung toxic medications. Another area to consider is pulmonary function testing and cystic fibrosis. We really hold on to, as we monitor progression of disease in cystic fibrosis, numbers, thresholds such as the FEV1. This is taken from the guidelines from the CF Foundation on when to refer children for lung transplantation. And we use this guideline of FEV1 less than 50% predicted as starting a discussion regarding lung transplant, and less than 40% predicted for referring for a lung transplant. Also less than 40% predicted for additional testing like annual 6-minute walk test, supplemental oxygen evaluation, and venous blood gases. So now you may think, based on the data that was shown earlier, that if a Black child previously had what was expected to be higher lung function, they may not be considered for some of these life-saving therapies, whereas now with the change in our reference equations, we might be identifying children who might be at risk for poor outcomes earlier. So I just wanted to highlight briefly what we've done in our own center. Removing the race identifier from our PFT printout was one of those lessons learned in terms of what we should make sure we incorporate as we implement these new guidelines, because we have parents and families tell us, you say that I'm a mixed race child or mixed other because of the reference equation that was selected, and that kind of turned people off. And then, as has been mentioned, switching to these new reference equations. And just the thing to point out is it's a little bit of a frame shift from thinking about percent predicted or percent reference to lower limit of normal. And perhaps looking at lower limit of normal is a more appropriate way of identifying who might be at risk or who may be suffering from disease early on. So just briefly to touch on, what are some next steps, or where should we be moving in this field and in this discussion of the use of removal of race and ethnicity in our interpretation? I think it's super important that we increase diversity of the population, diversity of the people who are incorporated in studies of pulmonary function testing. This was alluded to by some of my co-presenters. I also briefly mentioned this, but de-emphasizing the threshold-based decision-making, and rather than focusing on a percent predicted, focus more holistically on multiple factors rather than just the lung function. I think more information is needed on the relationship between lung function and meaningful health outcomes. This is an area that is definitely primed for future research. A big one is addressing the social factors that actually contribute to disparities in lung function. And when we think about children, perhaps it might be helpful to think more about lung function growth charts for children, as opposed to focusing on one specific number and really thinking about growth trajectories. And this isn't a new idea. This was published 30 years ago by Wang and colleagues in pediatric pulmonology, which are pulmonary function growth trajectories for children ages 6 to 18 years. And perhaps this may be a more meaningful way of moving us towards identifying more holistically what is the lung health of a child and who might be at risk for future lung diseases. And I have the privilege of ending on the same slide that Dr. Bhakta started on, which is the acknowledgement of this incredible committee of colleagues who helped to put together this workshop report, and I feel honored to have been a part of this group. And I thank you for your attention.
Okay, great. Thank you, everyone. Those were wonderful presentations. I do have a question in the chat that I just wanted to pose in the last couple of minutes here. I think this came in during Dr. Baugh's talk. The question was, how much of this is due to self-reporting of race, ethnicity in our mixed race population? Limb length to trunk length varies by race, which was the basis for racial difference in percent predicted values. Should we measure this to determine if corrections are appropriate? Anybody on the panel want to take that?
I'll provide a couple thoughts on that. Thomas, thanks for the question. One that we did consider, and one of the things is that we learned that although that has been used as a physiologic argument and biological argument that limb length differences are a basis for racial difference, we have learned that ideologically, that was not the only thread or even necessarily a dominant thread that led to the emergence of race-specific equations, but it was more about any kind of innate genetic difference and unfortunately also an inferiority in many cases. To the extent that, though, this idea was one part of the innate differences considered, the differences in limb length and trunk ratio leading to differences in function when adjusted for standing height, we have learned through a number of publications that that's quantitatively insufficient. It doesn't address even the majority of the percentage of differences between racial and ethnic groups, and that we expect the ratio of limb length to chest height to change in populations in response to social determinants of health, including early life nutrition and infections and other things that can influence the development of the chest and the lungs.
I'll jump in and take the first half of that question. I agree absolutely with the second. And Dr. Egan, I think that's a really insightful point you bring out. And it was part of my implication of my mention about changing demography, right? In that increasingly we live in a multicultural world. There is more comfort and more frequency of intermingling across racial ethnic groups. And so many more people will be reporting as mixed race. And so then what would the relevance of race-specific equations be as we go further down the line with that thinking? But then to interrogate the first part of your question, self-reporting versus what? And the question would be, well, how would you verify what someone's race really is? Like, is there an objective? And the answer, of course, as we've been saying, is no, there's really not, because it's this social construct, and it's a changing social construct. And so then how could we ever get an objective answer from something that was not objective at the outset? And I'll stop there. So we can go on to the next question.
Okay, there's another question in the chat. I think Dr. Liu had touched on this briefly in her presentation, but the question is there a significant difference between GLI Other versus GLI Global, and is GLI Global widely adopted?
Yeah, I would say, the big difference is in how it's actually calculated. So the GLI Other was sort of like an unweighted, just averaging people in all of the four major ethnic groups that they had. So it didn't account for the fact that there was 57, at least in the adult population that were in the GLI reference equation, there were like 50,000 people who identified as Caucasian versus only 3,500 people who identified as Black or African American. And so the GLI Global is a weighted average so that each group is thought to contribute more equally. In terms of the actual differences, I mean, there are slight differences, I would say, in terms of how it actually ends up calculating the percent predicted or the Z-score, but they're pretty close in terms of the actual number that you get back.
Yeah, the lower limits of normal are going to be slightly lower in your GLI global equation versus your GLI other. But again, whether you look at your GLI other, where you look at GLI global, and I know that the authors have in fact commented in some of their correspondence in the Blue Journal that they even looked at many other different weighting strategies, and that they get oftentimes very similar results across those. And so I do think there's something about how, about just, being on a single scale versus like, the particular weighting strategy that is used.
Okay. Well, we have a couple questions in the chat, but we're 5 minutes past our time. So I want to thank all the speakers. And if there's any questions, you can email to me or probably any of the other speakers as well, and I can distribute if there are any lingering questions. So thank you to ATS, thank you to the Clinical Problems Assembly, and to our moderators and speakers. Everyone have a nice day.